Thank you. I would like to acknowledge the traditional custodians of the land we are meeting on, the Noongar people. I wish to acknowledge and respect their continuing culture and contribution they make to the life of this city and this region. We have heard throughout the last few days, and it's not new to anyone here, the saying that you can't improve what you don't measure. Research is hard work, and more often than not, a huge team effort. I'd like to also acknowledge the staff and team of volunteers at the Salvation Army who day in and day out work tirelessly and voluntarily to support some of the most vulnerable people in our community. Professor Brett Williams from Monash University, Ambulance Victoria who supported the collaboration, and importantly Shamant, Shannon and Bronwyn for their work in collating and writing this project up. I work for Ambulance Victoria, I lecture at Monash University, and I'm the chair of the Australian Resuscitation Council for Victoria and the co-chair of the Lifesaving Victoria Clinical Board. There is much emphasis on technology and advancements, and I think you'll agree after listening to the sessions over the last day and a half that it is essential and technology is essential in advancing the clinical outcomes for our critically unwell patients. But the role of the paramedic is changing, and it's not all about that time-critical event. Paramedics are now faced with issues, both medical and non-medical, that may have previously not been associated with their role. There are growing mental health and social issues affecting different members within the community who now call an emergency ambulance service to help them. Expanded technical skills, but also expanded non-technical skills, such as empathy, compassion, situational awareness, communication, and interpersonal skills are essential. How do we prepare our paramedics for 2050 with the required non-technical skills to make a difference? Like all of your ambulance services, we too strive to deliver best care to every patient, every time, to achieve optimal health outcomes. One of the ways we achieve this is through case review and audit. For the most part, we have clinical experts looking at specific clinical skills that were delivered and making a judgment on whether this was in line with our current guidelines. If the care provided for the specific clinical condition being managed was outside the guideline, there would be a further review and often recommendations for some clinical training or some education and support to address the clinical knowledge gap. In my experience, when we don't provide best care to our patient, it is seldom an isolated clinical knowledge gap. Human factors, bias, and attitudes can all play a big part in our clinical decision making and ultimately the health outcome for our patient. We all have bias. That's the first bit, to understand and to acknowledge. The biggest challenge is how do we mitigate our own bias to be able to provide excellent care every time and not have this influence negatively our clinical decision making. One of those non-technical skills that I think is really important and has been shown to be important in a healthcare setting is empathy. In the healthcare context, professionals are often taught to detach themselves from patients and their experiences as a coping strategy for the difficult situations we sometimes face. While some level of emotional empathy is required, cognitive empathy is perhaps more important for healthcare professionals. That is, the capability to understand the patient's emotional needs as opposed to vicariously experiencing them. There are multiple studies examining the relationship of empathy and clinical outcomes, which demonstrate the importance of empathy in healthcare, the improved health outcomes patients experience when the provider shows empathy, suggesting that empathy would be an important trait for paramedics. Lower socioeconomic status is defined by those with lower levels of income, education attainment, wealth and employment, as well as those who are facing poverty or who are homeless. Catherine Eastwood wrote a paper in 2015 which examined the cases handled by Ambulance Victoria for the period 2009 to 2012 and reported a link between low socioeconomic status and an increased use of ambulance services. This map here, taken from the Victorian Government website, looks at local government areas and the incidence of admissions to hospital for heart disease. In this instance, those darker areas of higher rates of heart disease are all low socioeconomic status. Low socioeconomic communities have poorer education and understanding of health choices, in some instances poorer access to health care, and less ability to afford health care. They may also fail to understand the impacts in delaying accessing healthcare. Consequently, their health outcomes are often worse. In Australia, 78,296 people were recorded as homeless in the 2017-18 census, and of this, 18,510 were rough sleepers, meaning they spent the night in tents or improvised dwellings without any adequate shelter. Last year in Melbourne, the City of Melbourne Council conducted a street count over a 12-hour period and found 279 people sleeping rough just in and around the CBD of Melbourne. Like any member of the community, the homeless population should receive the same level of care from paramedics and thus should be afforded the same level of empathy. There is limited research regarding empathy and the homelessness in a paramedic context, and factors such as alcoholism, substance abuse, and mental illness are often associated with homelessness. These factors can lead to preconceived ideas, prejudice, and bias, and decreased levels of empathy towards stigmatised populations. Previous studies have looked at the empathetic attitudes of paramedic students and found that students had a higher empathetic regard for people with intellectual disability, but showed less regard for patients presenting with attempted suicide and substance abuse. This was attributed to the fact that the latter two conditions are considered self-inflicted. So if higher levels of empathy contribute to better health outcomes, and there are some identified vulnerable communities where perhaps less empathy is shown, how do we go about increasing the level of empathy towards vulnerable communities? There is some research in nursing and in public health which has shown an increase in empathy when working in community-based organisations. So we set about to look at whether exposure to vulnerable communities, in this instance the homeless, can increase the levels of empathy in our paramedic students. So we set about recruiting participants currently completing their second year of paramedic studies at Monash University. The requirement to participate was they needed to complete 4 shifts as part of a youth street teams program. So every Friday and Saturday night, the Salvation Army deploys 3 to 4 teams into the CBD from about 10 p.m. till about 5 a.m, depending on the number of volunteers that they have. And these people are all volunteers, and they go out with a pack with water and blankets and band-aids, and they have a vehicle that they use to pick up people that are happy to come and sleep at the Night Cafe, which is a building that's been donated in the CBD in Burke Street, and they go around making sure that people are okay, that they're not vulnerable, they're not by themselves. And so these people, so our students had to participate in at least 4 shifts or 40 hours. We used the period for a 2-month period because we wanted, that was the end of their semester essentially, and they were provided with jackets, with the packs. They had a 30-minute safety briefing prior to the experience, and then in November at the end of their experience they completed a questionnaire, and then we had a smaller focus group. The study design was a mixed methods sequential approach with repeated measures and a focus group to measure the impact that deliberate exposure to the homeless had on the empathetic attitudes of student paramedics towards the homeless. We used the attitudes towards homelessness scale and the medical condition regard scale. Data was reviewed utilising a thematic analysis approach. This analysis approach was chosen to provide a rich description of attitudes and perceptions towards homelessness. The transcripts were read several times to determine repeated themes, and these themes were subsequently coded, and a consensus was reached on the identified themes. All participants completed a written consent prior to participation in the interviews, and ethics approval was granted by the Monash University Human Research Ethics Committee. There were 20 second-year paramedicine students who participated in the study, and of these, 40% were male, 60% were female, and the mean age was 22.85 years. The medical condition regard scale was used by the paramedic students to answer each of the questions, with 1 equaling strongly disagree and 6 equaling strongly agree. The table outlines the mean medical condition regard scale scores for each question, as well as the total mean scores for the pre and post data. Overall, a statistically significant improvement, p less than 0.05, in scores was observed from pre-data to post-data. The greatest difference in individual mean scores was observed for the question, "There is little I can do to help people like this." The total mean scores of 48.35 and 51.65 respectively. Increases in empathetic medical condition regard scale scores were seen for each individual question, with all but 2 of these questions being statistically significant. This table outlines the mean scores for the attitudes towards homeless scale, both pre and post students' clinical experience with the homeless. Mean scores for personal advocacy were found to be statistically significant. Social advocacy also showed an increase post-project, and also the cynicism was an increase post-project. Following a thematic analysis of the focus group transcript, a number of common themes were identified that included communication, empathy and rapport, and a change in perception and attitude. And I'll highlight a couple of these now in some detail. Communication was a major theme evident through the focus group. Participants expressed that by participating in the study, they were able to practice and expand their communication skills. And the quote here in italics is from one of the students that participated. And their feelings were that they think communication is one of the big ones. Just when we speak to each other at uni and during scenarios and that kind of stuff, everything goes to plan. If you're nice to the patient, they're nice to you back. But it's not always like that. And I think having to speak to intoxicated people or people that don't necessarily want to talk to you and having to try and work your way around that and gain their trust was something good that came out of the salvos. Empathy and rapport were also themes consistent throughout the transcript. Having the opportunity to practice these skills, which participants felt they had not previously had the chance to, was repeated multiple times with statements such as, "We learn how to build the rapport, but that's something we don't get to really practice," which has helped us practice that. The other theme coming out from the transcript was a change in perceptions and attitudes, or more specifically, how the participants' perceptions and attitudes changed as a result of taking part in the project. One participant illustrated this by stating that you start talking to them and you realise they're not so different from yourself, and you think, why wouldn't I ever approach them outside of this situation? There were some limitations in the study. We used a convenient sample which was beneficial in gaining participation for the study. However, it also gave rise to a number of limitations. Rather than being chosen, participants were given the opportunity to participate, and this introduces a possible self-selection bias. There was no control over participant backgrounds or demographics such as previous experience with the homeless, which may influence the representativeness of the sample. In conclusion, paramedics in Australia are facing an ever-changing role, which requires them to expand both their technical and non-technical skills. The shift in the role to incorporate community paramedicine means that paramedics are frontline healthcare workers with a scope of practice that goes beyond the traditional role of solving purely emergency medical problems. The outcomes from this study have highlighted an opportunity for universities, ambulance services and training organisations to positively develop the empathetic attitudes of paramedics towards the homeless community. Thank you.